CICU devices.
Intra-Aortic Balloon Pump Nursing Care. This video is part of a series included in the Intra-Aortic Balloon Pump Guide playlist. The intra-aortic balloon pump is a temporary mechanical circulatory support device. It consists of a balloon catheter positioned in the descending thoracic aorta that inflates during diastole and deflates just before systole. It is frequently used in the intensive care unit in situations of cardiogenic shock, mechanical complications of acute myocardial infarction, refractory ischemia, among other clinical indications. You can find more information about the physiology and indications of the Iabp in the other videos of this series. The role of nursing staff is essential for achieving optimal outcomes in patients supported with an intra-aortic balloon pump. Continuous bedside presence allows early recognition of hemodynamic changes and device-related complications. Precise monitoring, accurate timing verification, and strict adherence to protocols directly influence the effectiveness and safety of counterpulsation therapy. Therefore, nurses play a critical role in maintaining device function, preventing vascular complications, and ensuring overall patient stability, as early detection and prompt intervention are fundamental to improving patient prognosis. Upon admission or bedside implantation, in addition to standard critical care measures, nursing care involves the immediate and systematic assessment of intra-aortic balloon pump electrocardiographic monitoring, inspection of the insertion site, confirmation of catheter size, balloon volume, and verification of the current assist ratio, identification of the vascular access route, and review of the patient's anticoagulation status. Although most contemporary intra-aortic balloon pump models incorporate fiberoptic pressure sensors, these technological advances do not eliminate the fundamental requirement for high-quality electrocardiographic monitoring. Rather, they complement optimal ECG signal acquisition to maximize device performance across a broader range of clinical conditions. Particular attention must therefore be given to the quality and reliability of the electrocardiographic signal, as accurate balloon inflation and deflation are critically dependent on appropriate triggering. In most cases, the intra-aortic balloon pump uses the R wave as the primary trigger for inflation timing. Therefore, a clear and stable ECG tracing is essential to ensure effective counterpulsation. Poor signal acquisition, electrical interference, low-amplitude QRS complexes, or frequent artifacts may lead to mistiming, resulting in suboptimal diastolic augmentation or delayed deflation with potential hemodynamic consequences. When the ECG signal is suboptimal, the intra-aortic balloon pump may also misinterpret the R wave, double trigger, or even lose trigger. The skin should be clean and dry, and when necessary, gently abraded to reduce impedance and improve electrical conduction. To optimize signal quality, ECG electrodes should be positioned according to the manufacturer's recommendations and institutional protocol. Generally, the correct positions are provided either on a diagram printed on the cable itself or in the device's instruction manual. Correct anatomical positioning of the electrodes is fundamental to obtaining a high-quality tracing suitable for triggering. In this regard, attention should be paid to the electrode placement system used, as there are two standard systems, the American Heart Association system and the International Electrotechnical Commission system. Modern consoles automatically select the ECG lid that provides the most reliable triggering. However, in certain situations, manual lead selection may be required to ensure optimal signal detection and accurate balloon timing. If an alternate lead choice is desired, the electrocardiographic lead that provides the clearest and most consistent R wave amplitude should be selected, minimizing noise and avoiding leads with low voltage or excessive baseline instability. Securing the ECG electrodes is also an important aspect of care. The use of transparent adhesive dressings can help maintain electrode position, reduce movement-related artifacts, and protect against accidental dislodgement, especially in diaphoretic or restless patients. This strategy helps prevent partial detachment or micromovements of the electrodes, which often manifest as intermittent artifact, loss of signal, or misdetection of QRS complexes by the intra-aortic balloon pump. Transparent dressings have the advantage of allowing visual inspection of the underlying skin and electrode contact. Cables should be organized and fixed to avoid traction, tension, or displacement during routine nursing care or patient repositioning. It is also recommended to maintain the ECG cables away from power cords and other sources of interference to further enhance signal quality. Arterial blood pressure monitoring through the intra-aortic balloon pump system is a fundamental component of hemodynamic management in patients requiring this type of mechanical circulatory support. Three primary methods are used for arterial pressure monitoring in patients supported with Iabp: direct monitoring through the catheter's arterial lumen, monitoring through an independent arterial line commonly placed in the radial or femoral artery, and finally, in modern intra-aortic balloon devices, the console obtains the pressure signal directly from the sensor transducer located in the tip of the catheter. The Iabp catheter incorporates a central arterial lumen that allows direct invasive measurement of aortic pressure from its distal tip, typically positioned in the descending thoracic aorta. This pressure signal is transmitted to the console and displayed as a continuous arterial waveform, which is used both for hemodynamic assessment and for timing balloon inflation and deflation. Accurate arterial pressure monitoring is essential to ensure appropriate device performance and patient safety. The methodology for monitoring arterial pressure involves the use of a dedicated, fluid-filled pressure line with minimal air and low compliant tubing. The pressure monitoring system must be level to the phlebostatic axis at the fourth intercostal space in the mid-axillary line, and 0 to atmospheric pressure according to standard arterial line protocols to ensure the accuracy of arterial pressure readings. Baseline calibration and system flushing are performed using sterile technique, maintaining the pressure bag at 300 mm of mercury to prevent blood reflux. The length of the pressure tubing should be minimized whenever possible to a maximum of 2 meters, as excessive tubing increases compliance and contributes to signal damping and delayed transmission. The continuous flush solution bag must be positioned at least 90 centimeters above the level of the transducer on a standard intravenous pole to ensure adequate pressure within the system and consistent forward flow. In other situations, a pressure signal obtained from an external monitor may also be used for Iabp synchronization. To enable this, an adapter cable is usually required to connect the pressure output from the monitor to the Iabp console. Third, contemporary intra-aortic balloon pump catheters incorporate fiberoptic pressure sensors that allow direct measurement of aortic pressure at the catheter tip without the need for a fluid-filled transducer system. This technology is based on optical signal transmission rather than a saline column, thereby eliminating many of the limitations associated with conventional pressure tubing systems, such as damping, resonance, air bubbles, or clot formation within the line. As a result, the arterial waveform obtained through a fiber optic sensor is generally more stable, more accurate, and associated with minimal signal delay. From a hemodynamic perspective, fiber optic pressure monitoring provides high-fidelity waveform reproduction with improved temporal resolution. The reduced latency enhances the precision of balloon timing, particularly during rapid hemodynamic changes or in patients with tachyarrhythmias. Because the pressure signal is measured directly at the aortic level, the waveform more accurately reflects central aortic pressure rather than peripheral amplification phenomena that may occur with radial arterial lines. From a practical standpoint, setup is straightforward. The fiber optic cable integrated within the catheter must be connected to the designated optical port on the Iabp console. Once connected, the system will prompt for zero calibration. In most current platforms, the zeroing process is automated after connection. However, during therapy, a new zero can be performed as described by the manufacturer. Unlike fluid-filled systems, fiber optic sensors do not require continuous flush solutions or pressurized bags, reducing maintenance tasks and potential sources of error. Learn more about fiber optic pressure sensors in our video, Iabp Physics. The link can be found in the description. Upon patient admission to the intensive care unit, the insertion site should be inspected carefully. First, the absence of active bleeding or hematoma formation should be confirmed. Second, it is essential to verify that both the vascular sheath and the Iabp catheter have been secured appropriately following insertion. Proper fixation is a key preventive measure against accidental displacement, bleeding, vascular trauma, and loss of optimal balloon position. The arterial introducer sheath should be secured to the skin using a silk suture, ensuring stable anchoring at the insertion site. The suture must be firm enough to prevent movement while avoiding excessive tension that could compromise skin integrity or contribute to local tissue injury. With regard to fixation of the Iabp catheter, securement to the skin may also be achieved using sutures placed according to the manufacturer's recommendations. However, dedicated catheter stabilization systems represent an alternative method of fixation. Adhesive securement devices specifically designed for Iabp catheters, such as stat-lock systems designed for Iabp, can provide stable fixation without the need for additional sutures at the catheter shaft. These adhesive systems are designed to minimize catheter migration while distributing tension away from the insertion site. In addition to providing mechanical stability, they may reduce the risk of local skin complications associated with suture-based fixation, including inflammation, discomfort, and potential local infection at suture puncture points. When securing the Iabp catheter to the patient's thigh, nursing staff should ensure that the catheter follows a natural trajectory without acute angulation at the insertion site, as tenting of the arteriotomy site can predispose to bleeding complications. Another important aspect of early nursing care following Iabp implantation is the proper securement of the helium tubing that connects the catheter to the console. This tubing is essential for the delivery and removal of helium during balloon inflation and deflation cycles, and therefore must remain unobstructed and protected from tension, kinking, or accidental disconnection. Upon admission to the ICU, nurses should verify that the male-female connector linking the catheter helium port to the helium extension tubing is firmly secured. In addition, the tubing should be checked to ensure that it is safely connected to the console. The entire tubing system should then be positioned in a way that allows safe patient care and routine patient movement without placing tension or mechanical stress on the catheter. The helium tubing should be routed carefully from the insertion site toward the console, avoiding sharp bends, and ensuring that it is not compressed by bed rails, patient positioning, or other equipment. Adequate fixation helps prevent traction forces from being transmitted to the intravascular portion of the catheter, which could potentially contribute to displacement or compromise of the vascular access site. For this reason, the tubing should be arranged in a stable configuration and secured according to institutional practice, often with additional fixation to the distal leg to minimize movement. In many modern Iabp catheters, the fiber optic cable used for arterial pressure monitoring runs parallel to the helium tubing. This cable must also be handled carefully to avoid excessive bending or tension that could interfere with signal transmission. Manufacturers commonly incorporate dedicated clips along the helium tubing to keep the fiber optic cable aligned and secured. Nursing staff should ensure that the fiber optic cable is properly inserted into these clips along the length of the tubing so that both components remain organized as a single unit. Accurate documentation by nursing staff at the time of patient admission is also essential. Several key technical parameters related to the device should be recorded in the patient's chart. First, the size and type of the Iabp catheter should be documented. Standard Iabp catheters are 7.5 to 8.0 French with balloon volumes selected based on patient height. 34 milliliters for patients of 152 to 163 centimeters height, 40 milliliters for patients of more than 164 centimeters, and finally, 50 milliliters balloons are available for larger patients. When available, the specific catheter model and manufacturer should be documented. The counterpulsation ratio should also be noted. The most common initial setting is 1:1, meaning the balloon inflates with every cardiac cycle. In some clinical situations, the ratio may be reduced to 1:2 or 1:3, typically during weaning or when assessing native cardiac function. The balloon filling volume or inflation percentage must also be clearly documented upon patient admission. The insertion site, femoral or axillary artery, and insertion method, percutaneous or surgical cut-down, should also be recorded. Another important aspect to verify at the time of ICU admission is the status of the console power supply and the helium level. Nursing staff should confirm that the console is properly connected to the electrical mains and that the internal battery status is adequate. This information can usually be checked on the console display or through the dedicated LED indicators that show whether the system is operating on external power or battery mode. In addition, the helium level available for balloon inflation should be reviewed to ensure that it is within an appropriate range for continued operation. The console interface typically provides visual indicators or alerts regarding the helium status, which should be verified as part of the initial equipment check. Upon admission to the intensive care unit, following intra-aortic balloon pump implantation, confirmation of the patient's anticoagulation status is an essential component of nursing assessment and ongoing management. Anticoagulation is used in patients supported with Iabp in order to reduce the risk of thrombus formation associated with the presence of an intravascular device and altered aortic flow dynamics. For this reason, intensive care unit staff must verify whether anticoagulation has been initiated during the implantation procedure, which specific agent was used, and the most recent dose and timing of administration. Clear documentation of the anticoagulation plan is required, including the target laboratory range, the monitoring frequency, and any planned adjustments. During the maintenance phase of intra-aortic balloon pump support, nursing care plays a central role in ensuring both the effectiveness of the device and the overall safety of the patient. Continuous clinical monitoring and systematic bedside assessment are essential to detect early signs of complications and to maintain stable hemodynamic support. Nursing management during this phase typically focuses on close monitoring of vital signs, careful management of the vascular access site, safe patient mobilization within established limitations, and the prevention of common ICU-related complications. Standard institutional protocols should be followed regarding nursing care, including infection prevention and pressure injury prevention measures. Hemodynamic monitoring and regular assessment of vital signs are fundamental components of patient care during Iabp therapy. Heart rate, arterial blood pressure, oxygen saturation, respiratory rate, urine output, and temperature should be monitored continuously or at regular intervals according to ICU protocols. Any sudden change in hemodynamic status may indicate a device-related problem or deterioration of the patient's clinical condition and should prompt immediate evaluation. Patient positioning and mobilization must be performed with particular care in order to prevent displacement of the catheter and vascular complications. In most cases, the Iabp is inserted via the femoral artery, so the patient should remain on strict bed rest in the supine position. This positioning helps minimize the risk of catheter displacement, vascular complications, or impairment of balloon function. Elevation of the head of the bed may be permitted, but generally should not exceed approximately 30 degrees. Nevertheless, regular repositioning of the patient within safe limits is important to promote comfort and reduce the risk of pressure injuries. On the other hand, for patients requiring prolonged Iabp support as a bridge to transplantation, insertion via the axillary or subclavian approach may be considered to facilitate greater ambulatory mobility. The Iabp typically derives its timing from the electrocardiographic signal, and the arterial pressure waveform, therefore, precise blood pressure readings, are vital for correct inflation and deflation synchronization. If the pressure monitoring system uses a fluid-filled pressure line, periodic checks should be performed. Recommendations include frequent verification of transducer leveling, avoidance of unnecessary line disconnections, and prompt troubleshooting of waveform artifacts. Nursing staff should routinely assess the arterial waveform for signs of damping, including reduced amplitude, loss of dichrotic notch definition, or sluggish upstroke. Additional care considerations include ensuring the integrity of all connections, preventing kinking or air bubbles in the line, and maintaining the Iabp catheter insertion site under sterile conditions. Recalibration of the transducer may be required to maintain accuracy, particularly when the patient's position changes or when the monitoring system is opened or manipulated. If the inner lumen waveform becomes damped, a structured troubleshooting protocol should be followed. First, aspirate and discard approximately 3 milliliters of blood to remove potential microthrombi or debris. If blood cannot be aspirated, the inner lumen should be considered occluded. In this situation, the lumen must be capped, and an alternative arterial pressure source should be established to ensure continued hemodynamic monitoring. If blood can be successfully aspirated, a rapid flush should be performed to clear the pressure tubing for at least 15 seconds. This maneuver should preferably be carried out with the Iabp console placed on standby to prevent inappropriate balloon triggering during flushing. Following the fast flush, waveform quality should be reassessed to confirm the restoration of adequate signal morphology. In contrast, in Iabp systems that use fiberoptic pressure sensors, the signal is typically very stable with minimal interference and latency. As a result, the need for recalibration or troubleshooting signal-related issues is uncommon. Moreover, fiberoptic sensors do not require continuous flush solutions or pressurized bags, thereby reducing maintenance tasks and potential sources of error. It is important to remember that blood should not be sampled from the inner lumen. In addition to continuous monitoring, relevant blood pressure values should be recorded periodically. These typically include the patient's native systolic and diastolic arterial pressure, the mean arterial pressure, and the augmented diastolic pressure produced by the balloon. Regular inspection of the vascular access site is essential to detect early signs of potential complications such as bleeding, hematoma formation, infection, or catheter displacement. The catheter and surrounding area should remain covered with a sterile dressing to ensure adequate protection of the insertion site. Transparent dressings are commonly used because they permit continuous visualization of the puncture site without the need for frequent removal. Dressing changes should be performed according to institutional infection prevention protocols. For example, one possible routine is to replace gauze dressings every 2 days, whereas transparent dressings should be changed at least every 7 days unless earlier replacement is required due to loosening, soiling, or loss of dressing integrity. Skin antisepsis during dressing changes should be performed using chlorhexidine at concentrations greater than 0.5% in an alcohol-based preparation. Strict aseptic technique should be maintained during all dressing changes, including the use of sterile gloves and a sterile field. The fixation system securing the catheter should be checked periodically to ensure that it remains intact and that there is no evidence of catheter migration from its original position. The integrity of the sterile sleeve should also be checked periodically. Assessment and maintenance of adequate perfusion of the limb is an important aspect of nursing care during Iabp support. Regular and systematic assessment of distal perfusion should be documented according to ICU protocols, often at hourly intervals. This evaluation typically includes observation of skin color, temperature, capillary refill time, and the presence of pain, numbness, or paresthesia. The limb should be compared with the contralateral extremity whenever possible, as asymmetry may provide an early indication of impaired circulation. Pallor, cool skin, delayed capillary refill, or increasing discomfort in the affected limb may suggest compromised arterial flow and should be promptly reported. Peripheral pulses, distal to the insertion site, should also be assessed and documented. When pulses are palpable, their presence and quality should be recorded regularly. In cases where pulses are difficult to palpate, Doppler ultrasound may be used to confirm arterial flow. Correct positioning of the intra-aortic balloon is essential to ensure effective counterpulsation and to prevent serious complications. A chest radiograph should be obtained following insertion and at regular intervals during maintenance, typically every 24 hours or whenever catheter migration is suspected. The carina serves as the most reliable radiographic landmark for confirming proper Iabp position. Positioning the tip of the Iabp approximately 2 centimeters above the carina provides appropriate placement in the majority of patients. In addition, nurses should routinely check the external portion of the catheter and verify that the insertion depth marking at the skin level remains unchanged. Many catheters include visible centimeter markings that allow easy identification of the insertion depth. If such markings are not available, reference marks may be made on the skin to help monitor the catheter position. Nursing staff should ensure that the helium cylinder is filled to the appropriate level. At the time of ICU admission and during routine checks, the helium level should be verified either on the console display or by checking the dedicated LED or gauge indicators, depending on the system. Replacement helium cylinder should be readily available in the unit, and nursing staff should be trained in the tank exchange procedure to minimize interruption of therapy. In general, the use of anticoagulation is recommended during Iabp therapy. However, in some cases, a no anticoagulation strategy may be chosen, particularly when the counterpulsation ratio is set at 1:1. The most frequently used treatment is unfractionated heparin. When anticoagulation is prescribed, nursing staff must ensure appropriate laboratory monitoring. The activated partial thromboplastin time is the most commonly used test for monitoring therapeutic unfractionated heparin, with a traditional therapeutic range of 1.5 to 2.5 times the control value. However, APTT results vary significantly between reagents and instruments, and the therapeutic range should be adapted to the responsiveness of the reagent and coagulometer used at each institution. In critically ill patients, the APTT may be affected by multiple confounding factors. Therefore, monitoring with anti-factor 10A levels is recommended at least once daily, with target levels typically between 0.3 and 0.5 international units per milliliters. Low molecular weight heparins and direct thrombin inhibitors, such as argatroban or bivalirudin, are not routinely used for Iabp anticoagulation, but may be considered in certain cases according to institutional protocols. In the critical care environment, checklists and flowsheets play a crucial role in supporting nursing staff by ensuring that no essential aspect of patient care is overlooked. Here is our proposed checklist to be completed upon ICU admission, daily thereafter, and after any transport for diagnostic tests or therapeutic procedures. First, confirm on the console that all prescribed parameters are correctly set, including the counterpulsation ratio and balloon inflation percentage. The insertion site dressing should be inspected regularly and replaced as needed to maintain sterility and prevent infection. Additionally, the date of the last dressing change should be documented. Verify that the catheter fixation system or securement device remains intact and firmly attached, ensuring that the catheter remains stable. Verify that the external catheter marking at the skin level remains unchanged compared with the previously documented insertion depth. Confirm that the sterile sleeve covering the catheter remains intact and properly positioned. Confirm that the console is connected to the mains power supply and that the display or indicator lights confirm that the system is operating on external power. Verify that the battery charge level displayed on the console is sufficient to allow safe operation in case of a temporary power interruption. Check the helium supply indicator on the console to ensure that the available helium level is sufficient for continued counterpulsation. Confirm that a backup helium cylinder is readily available in the unit and prepared for immediate replacement should the primary helium supply become depleted. If a fiberoptic cable is available, ensure that it is properly aligned and secured to the helium tubing using the manufacturer-provided clips. In contrast, if a fluid-filled pressure monitoring system is being used, it is recommended to perform calibration by zeroing the pressure transducer. Finally, nursing staff should confirm and document the dose and timing of anticoagulation administered during the Iabp insertion procedure, as well as any additional doses given during patient transfer or subsequent interventions. In addition, the anticoagulation regimen prescribed by the physician should be clearly documented, including the agent used, dosing schedule, and therapeutic targets when applicable. We also propose a separate checklist to be completed during each nursing shift. First, confirm on the console that the prescribed parameters are set correctly, including the counterpulsation ratio and balloon inflation percentage. Verify that the external catheter marking at the skin level remains unchanged compared with the previously documented insertion depth. Visually evaluate the insertion site for complications and document any abnormal findings, and confirm that the dressing remains secure, dry, and intact. If a fluid-filled pressure monitoring system is being used, it is recommended to perform transducer zeroing or calibration at the beginning of each shift. Confirm that the console is connected to the mains power supply and that the display or indicator lights confirm operation on external power. Verify that the battery charge level displayed on the console is sufficient to allow safe operation in case of a temporary power interruption. Check the helium supply indicator on the console to ensure that the available helium level is sufficient for continued counterpulsation. Confirm that a backup helium cylinder is readily available in the unit and prepared for immediate replacement in case the primary helium supply becomes depleted. Ensure that the helium tubing is firmly attached to both the catheter port and the console connection. Also inspect the entire tubing pathway to prevent obstruction or undue stress on the catheter. Assess limb perfusion. Compare the limb with the contralateral extremity to detect early signs of ischemia, check capillary refill, palpate pulses, or use Doppler ultrasound when necessary to assess arterial flow. Confirm the current anticoagulation regimen prescribed by the physician. Document the anticoagulant agent, dosing schedule, and therapeutic targets as ordered, as well as the timing and dose of the last anticoagulant administration. And verify the most recent anticoagulation laboratory results and the timing of the next scheduled test. In addition, this proposed flow sheet is intended to complement the standard flow sheet used in each ICU rather than replace it. It provides a structured framework specifically for patients supported with an Iabp. During Iabp support, continuous monitoring of the patient's arterial pressure is essential. These values should preferably be recorded directly from the Iabp console screen, as the patient's bedside monitor generally shows peak and trough values, rather than true systolic and diastolic pressures. In addition to the standard systolic and diastolic pressures, it is highly recommended to record at least hourly the mean arterial pressure and the augmented pressure generated by the Iabp. In cases where the counterpulsation ratio is set at 1:2 or 1:3, it is useful to complement the record with unassisted systolic and diastolic pressures, representing the cardiac cycle without balloon augmentation. The counterpulsation ratio at which the Iabp console is operating should also be recorded hourly. The balloon inflation percentage of the Iabp should also be consistently recorded. Finally, distal pulses should be assessed frequently, typically on an hourly basis, to allow early detection of ischemic events or compromised limb perfusion. The links to the proposed checklists and flow sheets can be found in the video description. These can be adapted to local protocols and procedures. More videos on these topics will be available soon. Helium cylinder change, battery change, zeroing pressure, and the switch to transfer mode.
If you've enjoyed our video, please press the like button and subscribe to support us so we can continue creating quality content like this.